welcome to the December 1st virtual TPA monthly membership meeting. As we give a moment or two for everyone to get settled in, I'll just make a couple of brief announcements. I first want to mention that our colleague Craig Douglas is enjoying his vacation right now. So with us today, I'm pleased to welcome in Ed Piccarini. Ed's here to provide some support to us in the background, join our discussion today as needed. So thank you, Ed, for jumping in. For anybody that wants to offer a question or a comment, I'd ask you please use the Q&A function. You're welcome to use the chat, and we'll monitor that best we can. But if you would like to jump in with a question or a comment, we'll do our best to monitor and introduce those comments into the discussion today. So also, of course, I want to thank and very soon welcome Kristen Ahrens, Rick Smith from ODP. I do want to cover a couple of announcements very briefly, but then we'll bring Rick and Kristen on for discussion, provide some updates for members here today. So with that, I'm going to move into the TPA updates. Again, welcome everybody. The first couple of things that I want to cover, we will be opening our annual member satisfaction survey today. You should get an announcement later today. Not a full-blown survey, just really just your feedback on TPA activities, meetings, resources. Please take a moment. We've tried to make this be very brief. We do this at the end of the year. We'll keep it open pretty much for the month of December. We'll provide some feedback to membership next year. Most importantly, we'll use this information to really meet your needs and expectations. So we really do encourage everybody to complete it, to be very forthright with us about things that are working for you that are not, so we can continue to improve our services to you here. So that will open today. I also wanted to mention a couple of upcoming meetings and events. So we do have, later this afternoon, we had some interest in people learning a little bit more about the rate appeal process with the recent publication of Needs Group 5, CPS, and some other therapy rates. So there is a session from 1 to 2 today. Our associate members, K&L Gates, will provide some overview, some guidance, answer any questions that you have on that topic. So Everyday Lives Conference, we want to remind everybody that that is, registration is open. That is January 9th to the 11th at the Hershey Lodge in Hershey, PA. I did see yesterday on the listserv, ODP announced the agenda for that. So maybe those are some things that Kristen will want to talk to us about momentarily to give a little overview of that. I did want to announce a couple save the dates. The Disability and Mental Health Summit, hosted annually by Representative Dan Miller. There are dates out for that, April 18th and 19th. So there'll be certainly some good content relating to IDA supports and services. It will be a 2-day conference. It will again be at Bethel Congregation in Green Tree. So you can look for some more information. I know they're taking registrations for the informational fair and some other things and some breakout sessions. So they will go back to sort of the format they were using several years ago. Also, something to mention, for the last couple of years, we've done a TPA summer conference at the Regional Learning Alliance in Cranberry. Pleased to announce that on July 26th, we will again be hosting that conference. And I've talked to Kristen and ODP, and once again, Kristen will bring a lot of her leadership team out to the RLA in July, and we'll do something similar to what we did what we did this last July, and probably talk a little bit about future of the system, maybe even today touch upon some of the things that you may want to see at that conference. We did just conclude the Center for Healthcare Solutions annual showcase. Again, I want to remind members of our partnership there. You probably get some emails for a number of training and educational resources. I want to remind everyone that those sessions are open to you. You're available to participate in them at no cost. So please keep an eye out for that, as well as we've had a number of members join the group purchasing organization that's now available, also through the Center for Healthcare Solutions. So, I do have on the slide unified advocacy priorities. I'm just going to defer that until a little bit later in our discussion as we talk some topics related to some of the rates and some of the things that Kristen and Rick are going to get into today. So with that, I certainly want to welcome in Kristen Ahrens, Deputy Secretary from the Office of Developmental Programs, Rick Smith, Director, Financial Management and Program Support. Rick and Kristen, welcome. Thank you for joining us today. Very pleased you could be here today to have a little discussion with our members and share some information with us. So I think the first couple of topics, I'm going to sort of jump to our next informational slide. This is right off of our agenda. So to the extent that you saw yesterday's agenda that we put out with the last call for the membership meeting here today, ODP policy updates. We want to talk a little bit about the current rate review that's underway, selective contracting. We want to, as I mentioned earlier, looking ahead to our summer conference, really sort of talk about the future of services and the vision. So with that, Kristen, I'd like to welcome you, and I'll slide over to your slide deck that you can take a run through with Rick.
Sounds good. Good morning, everybody. I figured we'd go ahead and start instead of with the policy updates. We've got a few different fiscal updates, so we'll let Rick get started with rate updates, needs group 5, and what we're doing with some of the supplemental payments. So we will jump right into that, and then we'll talk about some of the other policy changes.
Yeah, so good morning, everyone. Next slide, Ed, I think. There we go. Just briefly on the activity around the fee schedule. As a result of, we are pressing forward with the work to update the data behind the rates to the most current available, reviewing existing assumptions, and going through the whole rate setting process that we go through to update the fee schedule. So that work is ongoing. We expect it to conclude in time to include any proposals into the next year's budget. And I think, as Patrick noted, the updates to the CPS and transportation rates, needs group addition of needs group 5, and the group therapies were published as final last month, and they will be the needs group 5 therapies will be implemented. I mean, every CPS and transportation is same as it is currently. Needs group 5 will be going into effect on January 1st. And I think the group therapies are a little bit after that, if I'm not mistaken. Okay, next slide. So the recovery and expansion supplemental payments that were approved by CMS, we've done all the data analysis there and have those payments ready to go out. On the CPS side, there were 361 eligible providers, and about 216 were actually requested to receive the payments. So there will be about $21 million going out the door related to CPS in the next week or two. Employment side, a little bit better uptake. 62 out of the 95 eligible, and about $5 million in total. And SCOs similarly 31 out of 41 for about 6.6 million in total. We had in the announcement said that those payments will be out by the end of the year. We're hoping to beat that by at least a few weeks. We're still working through setting up the payment codes and things like that, so that has delayed me a little bit, but the calculations are all done. So those are ready to go. So that should be a nice Christmas present. Next slide. Oh, Patrick, I'm sorry. Did you want me to take questions during the?
Yeah, I was just looking at those, Rick. Sorry, that's why you had the delay on advancing slides. So yeah, I think maybe we can defer the discussion on rate. You're welcome to answer these. So we have a couple of questions in the Q&A about no rate increase this year with regard to the Mercer analysis. The rates have been developed by Mercer, who is the state's consultant, also developing selective contracting, where the rates developed to meet objectives of selective contracting. Yeah, Kristen, you can jump in. This is probably a broader discussion that we might have in conjunction with sort of selective contracting. Feel free to answer, Rick. I will say that we have certainly advocated around investment in rates first, based on inflation. Selective contracting is still under development. Certainly understand a lot of questions I think we'll address later. So if I can ask everyone to sort of defer questions around rates, selective contracting, kind of the interplay between them. I know there's some other information in this deck that does address that.
Okay, great. So I'll press forward, and we'll be here the whole time. So So regarding the needs group 5 and the new exceptional rate process, as you're probably aware, from the previous announcement, I think it was 22083, effective for the 1st of January, existing exceptional rates will transition to needs group 4 if providers have not performed a health risk screening on the individual, or needs group 5 if they have. So that's basically grandfathering in existing exceptional rates into, for the most part, needs group 5. Over the weekend, this weekend coming, needs group 5 will be functional in HCSIS. The rates are already in there, but it'll be functional in HCSIS Saturday, but Monday morning to update plans if you have not been able to do so yet. So folks that have their NEA rate segments end dated on 12/31 will need to do a critical revision to add the needs group 5 service to the plan. Going forward after January 1st, needs group 5 will be available upon request. It's not an automatic update to needs group 5. If you have an individual who's in needs group 4 and his healthcare level is greater than or equal to 4, you can request that he be assigned a needs group 5. And then the new exceptional rate, which is essentially a site level cost report, that form is available again through the rate setting mailbox. So if the needs group 5 rates do not work for you, for the most part, we hope that they will. We have done the analysis to say that they should for the vast majority of existing exceptional rates. But if they still don't work for you, you can, there still is a process to request an exceptional rate. That is, you might think we're going backwards here, but that is essentially a cost report for the home to justify that that individual has the staffing and he has the associated expenses to meet his needs. So it'll probably look pretty familiar to you, but it's a result of trying to cut down on the administrative burden, both from us and from you guys, and also we've come across, as the system currently exists for exceptional rates, we've come across quite a few exceptional rates where staffing patterns were submitted, exceptional rates were approved, and then staffing was not delivered. So this is in an attempt to get at that as well. So that new form, it was in the announcement that it was going to be released middle of November. It's available. Send the rate setting mailbox an email if you need it. Next slide.
Rick, sorry, if I can jump in, as we were taking some of the questions on the Mercer review, I'm just going to backtrack for a second here. So I had a question in follow-up. I think that the allocated amount of ARPA funds was around 40 million, maybe a little bit more than that. So is there going to be a repurposing of the funds? I thought one of the things that had been communicated was maybe those funds would be pushed out for these particular purposes for recovery and expansion payments. But if my math is wrong, just tell me. But like, you haven't spent 40 million here, apparently. I know we did even remind people after the deadline. I think some people did submit after the deadline. Are you still accepting applications for this, or are you going to repurpose those funds or perhaps push these out to people based on utilization criteria?
Well, I don't think we've made that decision yet, Patrick. I mean, it's certainly our intention to use as much of the available ARPA dollars as we can, whether or not that's through this particular initiative or repurposing to another ARPA initiative. That would be our intention. So, but I don't think that decision's been made yet.
Okay, and how long does the state have to use those funds?
We have until October 31st of 2024, per the current budget guidance.
Okay, thanks, Rick. And then on the needs group 5, I know that in response to comments. ODP pushed out ODP announcement 23-083. So clarity on needs group 5, just a couple things I want to make sure that I'm clear on. Needs group 5 is a classification that anybody would qualify for based on criteria. Exceptional rates are automatically going to port into needs group 5. And there is a form if needs group 5 is not acceptable by request, people can submit a cost report if the needs group 5 rates are not adequate for their needs currently. Does that kind of capture where we are currently?
It does, yes.
Okay.
So that exceptional rate cost report would be available to individuals in needs group 5.
Okay, I know a couple of questions have rolled, and I'll just see if there's anything that's sort of right on point with the needs group 5. What will be required in the request to move to needs group 5? We have a new individual who's receiving supplemental HAB. He won't have an NEA before the end of 2023. So what would be expected in 2024 to justify changing to needs group 5? So I think this gets back to the question of how do people qualify to be in needs group 5, just independent of an NEA process previously?
Well, as a result of their SIS assessment, they're assigned a needs group 1 through 4, or needs level 1 through 7, needs group 1 through 4. So if they're in needs group 4 and their health risk screening results in a healthcare level greater than or equal to 4 also, then they can just send an email saying MCI blah, 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 would like to be assigned needs group 5, and my staff would take care of that.
Okay. Is there a form? The form is out there. I think that's what's on screen now as far as how to request the form. We have a question on that. A question on supplemental payments. Supplemental payments are in process, Rick. Is that my understanding?
They are in process, yes.
Okay.
We will. I would think that we would at least do some kind of a broadcast email or something.
Okay.
When we have a firm date.
Yeah, that would be
firm
helpful.
date yet. Yeah.
Okay. Okay. I'm going to move on to the next slide in your deck, and then if I've missed anything, members, give it a shout out. We'll circle back.
All right, so we'll move on to some of the waiver amendments, and I'll just highlight some of the ones that are sort of pressing right now. So we did get, we had submitted a series of waiver amendments back in July. They included the rest of the rewinding from our Appendix K flexibility. So we were obviously under a deadline with the November 11th end date for Appendix K authorities. So we were pleased we got the approval from CMS, moved the remainder of the things that we wanted to continue post-pandemic into our standard waiver applications. Importantly, we did get approval, both budget approval in terms of the General Assembly and CMS approval to go ahead and launch our specialty telehealth and assessment teams, which we're calling STAT for short. We are beginning, the implementation of that will begin March 1st. And for providers that are already using this service, we know we do have a number of providers that have been residential providers who've been using this as part of meeting health needs for the people they support. We're actually working on a rollout strategy so that we can, it's not a one-off change to every individual's ISP, requiring team meetings and all of that. We're working on a process. We would like to do those sort of in batches to take the burden off of providers, SEs and AEs. So more to come on that, but we are working through how we would be able to just pull in every individual that is providers are currently covering through an arrangement. So working on that, stay tuned. The other things, obviously the addition of needs group 5 and then all of the group therapies were also included in the waiver. So we got the rate approval, budgetary approval, and we now have the federal approval to be moving forward with all of those. All right, next slide. So I'm going to point out just a couple of the things. So this one's time sensitive, which is why I'm really drawing this one attention to this one. In terms of the teleservices that we were using during the pandemic, for all of those during the pandemic, we just allowed the billing at the typical rates on the fee schedule. When we did the analysis, we were still within fee schedule for all of the services except community participation supports, which that analysis really indicated there was a significant discrepancy, enough such that we needed to develop a separate fee schedule rate for CPS teleservice. So if you are a CPS provider and you are using the teleservices, there is now a procedure code and different rates for teleservices. You will need to include those that procedure code and the authorization in individual ISPs no later than January 1st of this year, if you are providing that teleservice. The other thing to draw out here is we did with this waiver amendment, we eliminated the requirement for individual variances for individuals who are not accessing the community through CPS more than 25% of their time. We've changed the requirement there for providers who aren't meeting that integration target, that providers include that in the quality management plan. We did, put a bit of a buffer in there. We said if you've got more than, 10% of individuals that aren't meeting that standard, we would expect to see that in a quality management plan. We have a webinar to go through sort of the details of what we'd be looking for, how to operationalize that. That is coming up this next week. So that's a link, a live link to the registration. I would encourage CPS providers to attend that. I think we'll walk you through what the expectations are pretty well there. All right, next one. So that's waiver amendments. Do you want, I don't know, Patrick, if you wanted to stop there before I jump into state transition plan?
On the waiver amendments?
Yeah, if there was any questions or if you had anything you wanted to discuss.
Yeah, let me look for questions. I didn't see anything
Okay.
just a moment ago. Now you mentioned, I know at the webinar, it was mentioned, things you just mentioned around CPS, some of the changes there. So that is forthcoming, some guidance. I don't know that seems like it would affect, other than sort of compliance matters and making sure that things are good. I don't have anything further there to add. And members, if you have questions, and I've heard some discussion around this, like what's outstanding, how does that impact our ability to provide services? Those questions have come up.
Yeah, and I think the thing I would want to emphasize on this, the change from moving from an individual variance to quality management plan is, we're certainly aware that the workforce issues impact our ability to sort of carry out the objectives of community participation support and getting people into community settings. We understand that often requires staffing ratios that are much lower than somebody may otherwise have if they're receiving a facility-based service. And which is why, the emphasis on it being part of a quality management plan. We're going to be looking for evidence that providers are working with individuals and offering them opportunities and really doing the work to try to ensure that they have opportunities to access the community. But I think, we were pleased to be able to do this because I think it'll lower some of the administrative burden. I think it also means that we are looking at this at a more global sort of organizational level and at a systems level a little more effectively. So again, I think the webinar would be helpful to kind of walk through what the expectations would be and the evidence that we would be looking for, that providers are addressing this and ensuring, that we are offering every person that opportunity, whether they decide to take it up or not, but that we are offering them opportunities that are in line with their preferences.
Yeah, and we'll make sure, I know we've got a question about being able to sign up for webinars and guidance. So we'll make sure that we push that out or get that if that's a link on our site, something that we get corrected.
Well, and you can send this PowerPoint. It should be a live link in the slide deck I sent as well. You can
Okay.
certainly distribute this to your members.
Okay. Okay, thanks, Krista. We'll go next slide.
All right, state transition plan. So we did get we finally got our approval. Pennsylvania is one of the last 5 states to get approval from the feds for our statewide transition plan to demonstrate compliance with the home and community-based settings rule. And part of that was a lot of back and forth with the federal government about how we were assuring ongoing compliance. And I think as you all know, because I feel like we've talked about this to a great extent, you know, ODP really took the approach when the rule came out in terms of embedding the settings rule requirements right into our licensing and our program rules, so that we were evaluating, we're not doing sort of 2 separate evaluations. We're evaluating for federal compliance at the same time that we're evaluating for compliance with our own state rules. So the sort of third layer to that is we really had to demonstrate to the federal government how the monitoring done by supports coordinators also supports and ensures compliance with the settings rule. So we've done that effectively. They did approve our plan. If you go to the next slide, you'll see CMS is doing state site visits. They have provided us with the date that they will be coming to Pennsylvania. So they will be here the week of February 26th. They have already started some of the stakeholder calls that they're doing prior to this visit, but the purpose of their on-site in Pennsylvania will be to do a couple things. And remember, this is not just ODP, this is OCDEL, OLTL, and ODP. All 3 program offices have 1915C home and community-based waivers. So they will be looking not just at our program, but at all 3. Primarily, they'll be looking at OLTL and ODP. OCDEL's program is 100% provided in family homes. So I think there was much less concern because it's all one-to-one service in homes. It's paid through that waiver. So what they will be looking at, they have informed us, is they will be doing a deep dive into Pennsylvania's implementation of the settings rule related to person-centered planning and supports coordination. And then they will be looking at our corrective action plan and any milestones that we had. So for ODP, we did not need to implement our corrective action plan. We submitted one as sort of a safety net in case we had settings that could not come into compliance, that we had enough time to transition individuals to settings that could. But we ultimately did not submit any settings to the federal government. We did not have any that were not approved as meeting the standard. So I think we're in pretty good shape there. They have informed us that they will be doing service location visits. I don't know where those are, how those will be selected, but they will be doing some service location visits. There's some stakeholder calls, and then they will be conducting interviews with individuals who receive services, DSPs, and supports coordinators. So stay tuned. We've got a series of planning calls with them, which I think we'll know in advance where they want to go, who they want to talk to, what they want to look at.
Kristen, I missed from earlier. I'm just catching up with that. Planning and coordination had a limited appendix K of 1,040 units per individual. Does not appear in the new waiver service definitions. Has that limit been removed?
Yeah, I'm just reading that, and I do not know the answer to that. I'm looking if Michelle Poole is on here. It doesn't look like she is. I will have to get back to you on that. I do not know the answer to that question.
Okay, thanks.
All right. Anything else on CPS or the settings rule before I move on?
No, I think we're good.
Okay. All right, CIS updates. So we will be, I know in the response letter, the associations had sent a letter and we had responded to that letter with the findings from the AAIDD audit. So we had asked, based on the concerns that were being raised to us, we asked AAIDD to come in. They created the instrument, they own the instrument, they do all the training on the instrument. We asked them to come in and audit our vendor, KeyPro, and they conducted that audit, provided us with a summary of findings and a set of recommendations. Those are verbatim in the letter that we sent in response to the association's letter with concerns about the CIS. So you should all have that. So what I wanted to focus on today is and this is also in the letter to the associations, what ODP is doing in response to the audit findings and the concerns that have been raised by stakeholders. So first thing is we have been very eager to implement the second edition of CIS. Second edition of CIS, the AAIDD renormed their instrument, understanding that the acuity of the IDD population nationally has been changing, has been increasing in acuity of support needs. So they've made some adjustments, to renorm the instrument. And so we're eager to implement that because I think we have also seen certainly the acuity of need in our population increasing over time. So we're hitting go on that on January 1st. We have been working back with AAIDD and our vendor. We have also been in communication with some other states that are using, portions of the new second edition to kind of help us prepare for the implementation of that. So we're feeling like we're in good shape to begin that implementation on January 1st. Second thing, and this was very much from the findings from AAIDD's review, AAIDD expressed, and one of the things I should back up a little bit, their audit was very specifically, we asked them to look at where we had some discrepancies that had been submitted for discrepancy review, where a provider had said, please, we need you to take a look at this. So this was not just a random representative sample of assessments they were auditing. They do that kind of fidelity work on a regular basis with our vendor. So this was a specific audit to kind of get at the issues that we were hearing about. And one of the things that in their findings was that there were respondents were not reporting some of the things that then showed up in supporting documentation for the discrepancy reviews. So they shared with us that they thought we needed to do some significant work around ensuring that respondents were prepared, that we're doing good respondent selection, that people understand what their role is when they are participating in ASSIST. So we've done a couple of things related to this. We also heard from stakeholders that, generally since the 2008 implementation, for those of you who are around, there was just a flood of, I think, information that went out about CIS and, trainings for self-advocates, families, everybody in the field. I think we backed off on that a little too much. So we are really reinvigorating our effort to make sure that there are good training and resource materials out there. We have a new dedicated MyODP resource page that will house anything CIS related in one place so people aren't having to dig around for it. We have purchased access to AAIDD's Learning Center, where they have a lot of different training and tools that are available for all parties related to CIS and using CIS. We will ensure that there is good respondent preparation material and guidance so that we can avoid some of the issues that I think have certainly arisen and are pretty apparent when we're doing these discrepancy reviews. And then the last thing is we will have an updated SIS manual that supports both the second edition, but also addresses some of the issues that were identified in the findings and recommendations from AAIDD. Another area is that we have to, and AAIDD scolded us for this. You know, they said their instrument really is meant to be done, you know, every 3 to 5 years. They could see that Pennsylvania is, we are lagging in terms of our timelines, and that we have people that have gone more than that time period between their SIS assessments. And so we will be reprocuring our vendor, and we have been working on our ability to enforce the sort of deliverables and the timeliness of assessment. So I think we'll have some better tools to hold the vendor accountable in this next round of contracting. And then the last thing is improving the discrepancy review process. We do have a form that our team has been working on, so it will be a little more standardized process to submit for a discrepancy review. So I've got on SIS.
Patrick, there's a question on the SIS at the bottom. Will ODP continue to change what a provider is paid as soon as the SIS changes? Or will it do what's right and change what a provider is paid only after a new ISP is developed based on the new SIS?
So we did put, so we have, there's two issues here. Right now, one of the issues that we have is a limitation in terms of our IT. So providers, providers can go into HCSIS and look and see what the SIS changes, what the new SIS score is. But that is a active, not passive thing that providers would have to do. So we do know that there has been an issue with the timeliness of that. And so providers can request a 30-day exception. So we'll extend the, if it does require a rate change, we will extend that rate for 30 days. Our new enterprise case management, we should avoid all of this, I think, in terms of timeliness of active notifications to providers. And I do think we can maintain some time frame to ensure that the team can get together and work through any changes that need to happen in the ISP.
Yeah, a follow-up question. How will the renormed SIS affect the relationship between an individual SIS score and their residential rate? I.e. the SIS score may change under the new tool, but support needs remain the same.
Rick, do you have, I'm not sure.
Well, I was just going to say, in a big data world, the renorming should, since it's addressing greater acuity, that should apples to apples keep, the needs level assignment the same, or drive it higher. It will not drive it lower, I guess, is my point.
Yeah, and I think related to the
Right.
question that Ed read out. So I know in the letter, and apologies, we're not able to get everything posted to chat like we normally do, but we've pushed these things out. All these letters that we reference and announcements should be also available instantly on our website too, as we kind of call some things out. But the reassessment, so your letter indicates if needs group does decrease by 2 or more, that reassessment can be requested. So any gap between, somebody's gone from 4 to 2, there's a reassessment. The gap in the middle in terms of funding and reimbursement, is there a policy decision on how that will be managed, or is it going to be, we've reassessed and we agree there needs to be a change, it's elevated again, but are we going retroactively to sort of override something that resulted in a decrease in level of 2 or more, or is that gap going to remain? Rick, I'm not sure if we have lost Kristen or maybe we've lost me, but
Patrick, I don't know that there's a specific decision on that question.
Okay,
I mean, I would say that it should go both ways. If there's a, you know, if there's a decrease in the needs level or an increase in the needs level, it should probably go both ways. But I don't think we've made
yeah,
that
understood. You know,
specific
I
call
think
on this decision.
yeah, thanks, Rick. I raised it because of, you know, concerns over, you know, training and education, always a good thing. I think, you know, everything that's been addressed to gain more information, more insight into what the issues are. But I think in instances where, you know, certainly if there is a reason to change and reduce needs group and assessment levels do truly change. I think most of the instances, of course, I've heard about, and probably you folks as well, have been those that have been in dispute. So to the extent that there's a drop and it's recognized for whatever reason, let's say the person indeed wasn't appropriately supported, if the questions weren't answered properly according to AIDD policy or whatever the issue might have been, if there's a correction, and you don't have to answer it on the spot, I just want to make the case that if there is something that it's been acknowledged, this dropped, it should not have dropped, and there ends up being a 6-12-month gap in between that assessment, that has real implications for the person being supported and the organization or family to be able to provide those support. So we just want to make the case that we want to make sure that that is right-sized appropriately to whatever the proper assessment level is.
Yeah, and I think I lost my connection entirely there for a second. But yeah, I think your question was related to the notation and the letter to the associations about reassessment. So we will put some parameters around that, what the time frame is, the sort of look back time frame for requesting an assessment under the SIS, this second edition. And again, we will require an attestation that providers are doing the prep work for the respondents, because for the team that reviews the discrepancies and the AAIDD team, in most cases, it was, you know, there was new information that was being presented with the documentation submitted for that discrepancy review.
Mm-hmm.
So we want to address this both ways. Let's make sure to get good respondents when we have the second edition, and we'll do that. But we'll put some parameters around that and get that out once we are into the implementation of the second edition.
Thanks, Kristen. And I think this is a follow-up to the probably original question to kick this off, but the SIS is only a tool. The ISP should drive what a person receives and in turn what a provider delivers and is paid for. So I don't want to miss that point. You know, I don't want to gloss over that, but that should be a tight process, of course, but it should be an ISP process. So going in both directions, and I guess we would probably all agree with that.
Correct. And I think it goes to that timing question too. Like we understand that when those things change, that there should be, the ISP team's going to need a little bit of time to make adjustments one way or the other. And that we've got a notification issue. You know, we don't have we have a notification system. It's not a great one. So we've got to get that corrected and then allow teams some time to do that work.
And also, just to clarify, I mean, there does have to be a ISP review and revision when a needs group changes.
Yeah.
So that can't happen without the ISP critical revision.
Okay, where do we need to pick up here, Kristen?
Well, if there's any questions on the state transition plan, I can see one question I think is probably related to the state transition plan. There's a question, is CMS concerned about remaining state centers, and were they bothered by closed state center residents moving mostly to other state centers? We have not heard anything from CMS related to the closures of the state centers. All right, so let me jump into performance-based contracting. So you're the first group to hear. We're no longer going to call it selective contracting. We are going to be calling this performance-based contracting going forward, which I think makes a whole lot more sense. It is really what we're doing. We use the official term right from the federal application. That is the technical term for what we are going to be requesting from the feds, but that doesn't mean that's what we have to call it. So you'll hear us referring now to performance-based contracting, which I think better describes what we're trying to do here. Let me give you an update as to where we are. So Patrick had asked me to talk a little bit. I was asked by the National Association of State Developmental Disabilities Directors to do a session at their conference, which was a couple of weeks ago, on what Pennsylvania was doing in terms of waiver changes and moving to performance-based contracting. And Patrick asked me to talk a little bit just from that kind of national perspective, what that was about, and what a little bit to the landscape. So the session at NASD's was, there's a lot of interest in the session, in part because there are states who use selective contracting in the way that we are going to be using selective contracting in terms of the federal authority. Primarily, so there are two ways that states do that. States that are managing it themselves, which is what Pennsylvania is planning to do, which the authority using the B4 will be the state. There are other states that do that, primarily around supports coordination. So Oregon, Minnesota, Indiana was the most recent, I think, to move to using selective contracting for supports coordination. So number of instances where states have done that specifically to kind of manage supports coordination a little differently. A lot of interest. The session that I was asked to do is specific to residential because no state is doing this using this tool in terms of residential outside of states. So there are some states that there are in 1915B, that section of federal statute within the Social Security Act. 1915C, that's what gives the authority to do home and community-based services. 1915B has a number of sections to it that are all about how you manage services within a state plan. So not typically, there are lots of examples where B4 is used in conjunction with B1, B2, sometimes B3. In Pennsylvania, we have that. That's typically done under managed care. Commercial managed care organization is operating and using those authorities in terms of management tools. So that is not new. There are some states that use some of the other B authorities in conjunction with B4. So North Carolina is one of them that has a managed care model. Arkansas has a managed care model. Tennessee has a managed care model where they're using the B4, but in conjunction with others. So Pennsylvania would be unique in using the B4 with the state as the operating authority and using it for residential. So that is unique. And again, that's, I think, part of why there was some significant interest from a national standpoint in terms of the direction that we're trying to go in Pennsylvania. So Patrick, I hope that answered what you were, I know you were interested in hearing what the NASD's presentation was and thought your members would be interested.
Yeah, definitely. We get the question because, as you noted, the B4, the 1915 B4 prevailing authority, it's a managed care waiver, basically, right. Correct? So it doesn't necessarily mean other states are doing anything similar at all. So states may have this B4, they're doing managed care somewhere. And what little research we're able to do, I mean, it's most important to kind of hear from you in terms of the research you've done, the work you're doing with Mercer, with the work group. But I'm also curious, so what was the reaction to the audience on some of this? And what kind of questions did you get from other states in terms of direction, or did they offer any guidance to Pennsylvania being the leader so you could deliver some information back to them?
That was a lot of questions. So let me try to respond to that. So I mean, I think the reaction was general interest because I think, for the most part, nationally in the IDD, home and community-based services space, there is justifiably a lot of concern about commercial managed care and the ability of commercial managed care to work in this space. And so whenever you start talking about tools that are typically associated with managed care, I think people are interested in looking at different management tools. Fee for service, states are experiencing the same thing we are. Workforce issues are horrendous. States are experiencing, many states have waiting lists just like we do. Many states have system sustainability problems just like we do. So I think there's a lot of interest in what are some other ways to look at managing our system that don't involve commercial managed care, that give us a little more room than typical fee for service. So I think I would say generally there was quite a bit of interest in the concept and idea. There was a lot of interest actually in the performance standards document. Like people were asking, can we have this document? They were very interested in kind of how we were thinking about performance and outcomes, how we were thinking about measuring it, how we were measuring it, the pay for performance standards. So quite a few follow-up. I had a number of follow-up discussions. A lot of it was around some of the specifics of how we were trying to address workforce in it, how we were trying to address some of the quality concerns.
Okay, thanks. So follow up, I guess, just from me. So when you have these conversations with other states, if we talk about this as an alternative to commercial managed care for performance-based contracting under, broadly speaking, selective contracting, are there states that see this as the permanent solution to managed care without commercial managed care versus some states seeing it on a pathway to eventually bring in commercial managed care? I don't know if that question's clear.
Your question is somewhat clear, and I can't answer it. I mean, I think this is you have states again doing managed care. You had New York that looked at a little bit of trying to do a public authority to use some of those managed care tools. So I think states are kind of all over the place, and we all have unique systems. So even though there's a lot of shared issues, like the workforce issue is shared, there isn't a state without the workforce issues. There's very few states that aren't struggling with the sort of sustainability issue, if not all of them. But we are all working in slightly different environments with different histories to how our systems came up. And so I think each state has to kind of think about how they're structured, what their resources are to figure it out. There are states like us that are very county-based. There are states that are not county-based at all. So, really different environments to kind of think through what management and financial tools are at our disposal to help us get at those outcomes. So I can't answer more broadly where the spectrum of states is on that.
Sure. No, understood. And then, so how about for Pennsylvania? Are you comfortable saying that this is where we want DHS ODP to manage this system for the foreseeable future?
I'm not. Yes.
Okay.
Yes.
Yeah, just to make sure there's
100%. Yes.
DHS,
Absolutely.
Yeah. Okay. No, I just wanted to bring that out very explicitly, that this is modeled after ODP running the system, not farming that out. I know you had questions about the administrative back office support. Was that leaning in a direction of commercial managed care? So just for clarity, understood. This is the model that we're pursuing. It is not a pathway to something else.
Here's a question. If no state is using supports coordination or selective contracting for residential, but you're placing supports coordination in year 2, why not reverse the introduction and do supports coordination before residential?
And this was a huge question as we were deliberating all of this and what this looked like and how we would do this. And the reality is that the quality concerns in our residential, between quality and sustainability concerns in residential right now, residential has to go first. We have to begin addressing those concerns in terms of residential services and how much The residential component of our system drives the many of the other issues in our system. So it is a very legitimate, very good question. It is something that we struggled with and really deliberated through. But we have got to start with residential. And if you look at the document that we put out on November 1st in terms of the performance measures, one of the things that I think you will see in it, and I can't reiterate enough, is this is a beginning for us. This is us starting to lay the foundation. There are multiple places in, we'll bring in all of the residential providers. We've established some standards. Many of these are going to be, track and use, report the data. This is us really beginning the process of greater quality improvement within residential services. And we have got to start that as soon as possible. So no, that's a very legitimate, very good question. And that is why we have got to address these issues in residential now. Okay.
And with that, you are having your first meeting with supports coordination here.
We are. So supports coordination starts. We are still, that will still be a year post in terms of we'll get residential off the ground January 1, 25, supports coordination off the ground January 1, 26. We did get surveys, residential surveys back. We did not have a 100% completion rate, which we should have because it was a required survey, but we did have 19% of providers did not return the survey. I will tell you, it was not much of a surprise. Many of those you've heard me talk about licensing and all of the enforcement actions we're taking. If I pair up the list of the providers who did not return the survey with the list of providers who are under enforcement action of some sort, it's pretty good overlap there. So we've got very significant amounts of data that were submitted that we are working with Mercer to do the analytics around. So we will be able from that to start plugging in some of the additional information into that performance standards document. Supports coordination strategic thinking groups meets next week. They're going to have very similar sort of objectives to the residential strategic thinking group in terms of hammering out the specifics of the performance measures, looking at where we will apply some of those financial tools in terms of pay for performance. So we'll, that'll carry on for many, many months as we work through that with supports coordination. All right, next. Just to bring you up to speed, in case you haven't heard where we landed in terms of the different tiers and how they're characterized, what we'll be using in terms of financial tools to support performance-based contracting. We did land on ultimately 3 provider tiers. If you recall, we started with 4. We now have 3. So in terms of the that upper tier, we have 2. One is select residential, this is providers who demonstrate that they can meet some additional quality standards, including that continuum of care. They're going to have 2 of the 3 types of residential services they provide. The clinically enhanced, which is providers that have demonstrated they've got that clinical capacity for either or both medical or dual diagnosis. Both of those will be pull down enhanced rates and can also draw down value-based payments, the pay for performance. Primary, which is the sort of standard provider, will meet all the contractual obligations, does not receive enhanced rates, but will receive the fee schedule rates, much like they look today. Obviously, we're all anticipating that we'll have some new rates this next year. And then, yes, also eligible for the pay for performance. And then the conditional providers are those providers that are under some kind of enforcement action and will not be subject to enhanced rates, will not be subject to, cannot draw down the value-based payments either. And one of the things I want to say here is, I think there's a lot of discussion, and I don't know if any of our work group members want to chime in here, but Definitely have heard a lot of discussion about providers thinking that they, somehow are going to need to meet the clinically enhanced or the select residential. And that's not the case. We need a group of primary providers that meet all of those requirements. We do not need all providers to meet the select or clinically enhanced. Those categories will remain in place. I don't really foresee a future need where we wouldn't need those different categories. So just to be clear for providers who are concerned about meeting those standards or the pressure of meeting the standards for select or clinically enhanced. We did have work group members saying, I don't know that I want to go for, being a select residential or clinically enhanced. Meeting the standards, drawing down some additional funds, value-based payment sounds great. As a primary provider, I don't know that I want to take my agency in that way. And that is fine, like perfectly acceptable. And we would anticipate that that is a decision that a number of providers make.
Kristen,
All
there's a question in the chat from Gary about Etnathes. You suggested that the selective contracting model would yield savings in residential by improving a variety of factors, including better clinical supports. Have any families expressed concerns about potential adjustments in residential supports?
I feel like that's two questions or a statement and a question. So I'm going to address them separately. One, on the yield savings. I do think that these changes will long-term, these changes in residential will help us with a more sustainable system, meaning bending a cost curve and allowing us to bring more people into service. This is why we put out the outcome-based payments for life sharing and supported living a long time ago. This is why we have such a robust array of services that support people to hopefully not need a full residential HAB service. ResHab is a very expensive service and should be used for people who really need it. So I think to the extent that we can support people in less restrictive, less expensive settings, really use residential where it is absolutely needed, that will create better long-term system sustainability. So yes, I do think we're not going to see that immediately, but long-term, this is the trajectory a system needs to be on. In terms of families expressing concerns, let me read that again. Oh, lost it. I lost Gary's question. I think your question was related to families expressing concerns. We have families who have are on both sides of this. Families saying, I am so concerned that my loved one is not receiving what they need in the residential setting, that the staff do not have the skill to support them. I am very concerned about that, and a lot of excitement about the direction that we're taking in terms of really trying to address the clinical needs. And we have had families express concern that there will be fewer choices of residential providers. I mean, I think the general concern that's been expressed that this will shrink the field. So we have absolutely heard both of those things.
Kristen, let me jump in. I know we have some questions about meeting links in the chat. I'll just promise everybody in attendance today, we will send out everything we intended as handouts, all the links that were active or referenced here, so you can sign up for various trainings. And with regard to what's on the slide currently, Kristen, so can you comment on any difference between the two A levels? So if you're doing both, is there an anticipated difference between select residential clinically enhanced?
There is, and if you look at the matrix that we came out to the residential strategic thinking group and was provided to all of the associations, you will see that there are two distinct paths. Select really is about having a continuum and meeting some additional quality standards. Clinically enhanced is really about, I mean, this could be a very small provider on clinically enhanced that has that clinical team in place to support individuals with high acuity of need. So this was very much this split, and the design of this was very much around this notion that the concerns that we had, that small providers would not be able to, small or specialty providers would struggle in the environment and the concept that we had initially put out. So the work group spent a lot of time crafting sort of two paths to that top tier, that I think addresses one of the system needs, which is, improving our capacity in residential services to support people with high acuity clinical needs, while addressing, still moving to life sharing, still moving to more supported living, still raising all of those other quality standards. So I think the design of it is pretty elegant in terms of how the work group really crafted those two different paths.
Yeah, how you get there, but will there be a difference between the enhanced rates between select residential and clinically enhanced, or do you see them as being different rates being billed? It's a little unclear until we can sort of see it laid out in the tiers. But the question is really are those going to be comparable rates? So the A tier rates going to be roughly the same?
I can't answer that question until the data analysis is done.
Okay.
Patrick, there's another question in the chat, the Q&A from Stacy. Will providers need to meet all of the standards for select or clinically enhanced to be in those tiers? If we only meet 14 out of 15 for select, will we remain as a primary until we are able to meet the last standard?
Yes. Yeah, so there will be, and this is part of the other piece that we obviously will need to articulate before we send this off to CMS, but there's been a lot of questions. So if I miss, one, what does that mean in terms of like, do I drop tiers, et cetera, et cetera? We will obviously have to have some nuance in terms of, we're not going to expect 100% compliance with all of those. So we will have to have some nuance in terms of that. But generally, yes, you would have to meet the standards for all of those to be in the enhanced or select.
One other question, and Patrick, unless you want to continue with the slides, but it said, can you be more specific in what a clinically enhanced program would look like? Is there a model you were looking at? In other words, how do we know whether we qualify as a clinically enhanced provider?
So I would say to the person who submitted the question, look at the document. What's missing from the document is the percentages and the numbers that you're going to have to meet to be considered clinically enhanced. But the standards are there that distinguish between a primary and a clinically enhanced, or a select and a clinically enhanced. What the numbers that we have to still plug in there are, what is the composition? What are we expecting in terms of clinical staff to individuals supported? What is the acuity of the population you support? There's some training, there's some credentialing. So there's still some specifics that have to be plugged in, but you will get the gist of it from looking at the document that I referenced.
And I remind members that we have a dedicated section of the Learn page now to selective contracting, which we'll now have to rename. But all these documents are out there, including the November 1st draft. And what you're pulling from, Kristen, correct, is from the November 1st draft that is really the product of the work group, ODP and Mercer.
Yeah, and until that, I don't anticipate that draft changing until we are plugging in numbers from the data analysis from what we have and from what we just collected through that survey.
And Kristen,
oh, sorry.
Just being on, on the work group, I think your staff did a great job with that, and it was a great process. And I think it's really a path that's going to get you to where you want to go in terms of the selective contracting or the performance based. I think just something you said earlier about some providers choosing to be, just stay at the level, the regular level rather than enhanced or a higher level, is the enhanced rates. One of the concerns I think a lot of us have is if we don't get to that higher level, and our, you know, the other providers do, and they're getting enhanced rates. How will we compete with staffing? Because if people started paying staff $1 or $2 an hour more, and I'm not even suggesting there's an answer to that. I'm just expressing, I think that's a concern as I talk to other providers. That'll make it really difficult to stay in the mix if people are paying $2 an hour more than us to do residential services, or whatever the number is. But just expressing that, you know, it's the conversation providers are having about it.
Yeah. And I think to some extent, we're already seeing some of that in the field, right? We have, and we have some huge disparities between wages that providers pay. Some of that goes to comp package plus wage, and sort of where agencies have come out in terms of that split with investing in DSPs. I think that also is, I mean, we have providers that have served you know, individuals who they have a significant number of individuals who are needs group 4 or had needs exceptions who are paying those higher wages. So I think to some extent that is already happening, but I appreciate the comment, and I do think that is a concern that we may have to pay very careful attention to. One of the other opportunities that I think will come with this, and you've all heard me talk about this before, as we move to DSP credentialing, ODP firmly believes that we should be tying credentialing to wages, and that those assumptions need to be built into our fee schedule, our rate structure, to appropriately compensate based on, you know, DSP 1, 2, 3. And so I think, you know, this gets us started on that journey. In this case, we're looking at using some pay for performance to help support that. But I do think as we get more of a credentialed workforce, this is something that we should be assuming. And to your concern, Ed, and I hope that will help to address that too, because we would have a sort of assumptions and some structure built in to be paying those credentialed DSPs at a higher wage, and to be, you know, primary. I think as we go on, we'll see those, you know, I would imagine we'll see standards starting to develop for the primary providers too, related to credentialing.
Great, thanks.
Yeah. Okay, so I've only got, I will stay till 20 after I have to get to a meeting at 10:30 that I need to prepare for. Let's go ahead to the next. One of the things I wanted to talk about, and we can, you know, I think maybe we spend some concerted time on this when ODP is out in July, but just to get people starting to think about is how nationally and here within PA, the IDD system in general, home and community-based services in general, there has been this shifting focus to trying to look at outcomes, understand outcomes within a home and community-based environment, and physical health and behavioral health. You know, we have standardized measures that we can look at that, you know, kind of get at these outcomes. And we're definitely seeing a shift in terms of both a national movement and what we're trying to do here in PA. So Patrick, if you can go ahead to, yeah, I'm going to have you skip the national stuff and I can come back to that another time. But if you go to slide 16, wow, you're good. One of the things I would just want to kind of get everybody thinking about is, if you look at the matrix with all the performance standards for residential, and if you're not a residential provider, I think that's still really instructive for you to look at, because I think it does help lay out some of what needs to be happening in our system in terms of the sustainability, in terms of overall system quality. You're going to see a lot of overlap with the supports coordination for the same reason. And so I think it's important to understand that, you know, here in PA, like the feds just did with the quality measure set, trying to start getting at what are some standardized measures that we can look at. This is also what we are trying to do here in PA is how do we really start understanding, thinking about, and paying for outcomes that we want in our system. And that falls into two things, right? Individual outcomes and systems outcomes. I think we have identified some really good performance areas related to this for the performance-based contracting. And when you look at this, it's individual outcomes. Are we getting people employed? Are they meaningfully engaged in their communities? System outcomes. Are we addressing the workforce issues? Are we raising the quality of the work that our DSPs are doing? Are we using less restrictive settings that are less expensive so that we can get at the waiting list, right? So what are these sort of system outcomes? What are the individual outcomes? And then part of what we have is we don't have a lot of standardized measures to rely on. So the way I think about this, I think about this in four ways, and you will see this when you look at the document. There are places, and the extent that we could, where there are standardized measures, we're going to use them, right? So you'll see we're going to use NCI in there. That's a standardized measure. We've got a couple of HEDIS measures in there that come from the physical health system. We're going to use those. Those are standardized measures. We've got lots of other data that we can use to compare that to. Then we have areas where we have data and we know that we can capture that outcome. We can capture performance based on that. So employment is easy, right? Somebody's employed or they're not employed. They're seeking a job using supported employment, or they're not seeking, or they're not engaged in anything supporting them to gain employment. They have transitioned from ResHab to supported living or life sharing. Like, those are easy to collect and measure. Then we have areas where we have data, but we don't have a clear understanding of it. So this is, you'll also see this. We have tons of data on things like restraint use, restrictive procedures, on law enforcement involvement, inpatient hospitalization. We have all these data. Can I tell you what a good outcome looks like in terms of those data? Not yet. And so part of this is us coming to a common understanding of these performance standards. What does this look like at a provider level? What does this look like at a population systems level? And then what should we be aiming for? So some of these are, again, they're clear. Fidelity to health risk screening. We could, are you completing all of the screening in a timely fashion? Incident reporting fidelity. Have you reported all abuse and neglect? Those are much easier to determine than what does good performance look like in terms of restraint reduction, polypharmacy, chronic diseases within our population. We don't know some of those. And so part of this is our system getting familiar with what those standards should be, establishing some targets, and then adjusting them as we get better at this, as we learn, as we get better. So this really is, I've said all along and really tried to emphasize, and this is, I said at the beginning, we're starting with residential because we've got to start doing this work in terms of quality improvement and sustainability. So we're really building a foundation, and we will adjust that. As we get more credentialed staff, we will adjust the target for credentialed staff. As we all start watching and understanding and learning about referrals and discharge procedures and practices. I can't tell you today what the data should look like there. We don't have data. We need to collect it, and we need to understand what it's telling us before we can set any targets that make any sense related to referrals and discharges. So again, this is truly a systems level continuous quality improvement process. And if you go to the next, and then I'm going to have to drop off within a couple minutes here. You'll see there are areas where we are really developing those outcomes. So how do we know what good service provision looks like when it comes to supporting individuals with complex needs? We can, when you see it, right? But if we're doing this from an objective data standard, what does that look like? What should that look like? what does family engagement look like? We're going to start collecting data on family satisfaction. Can I tell you where we should be, what's realistic, what we should be aiming for realistically? No, I can't. We're going to have to collect that data and start understanding that as a collective group. All right, go to the next one. And so to that end, we are starting the provider, Isaac has a new subcommittee that will begin meeting in March called the Provider Performance Review Subcommittee. And really the point of this is that as a IDD system, we all start getting really familiar with all of these kinds of data points. What does it look like at a system level? How do providers sort of distribute in terms of performance across that? What are we measuring? How are we measuring it? And what does it mean in terms of actual outcomes for individuals or systems? So we will be, the subcommittee will start meeting in March. The data and information from that, we're looking to do some provider forums so we can also be making sure providers have a good understanding of the data that we're looking at, what it means, so that you can interpret that for yourselves and kind of put yourselves in comparison to other providers system level statewide data. All right, Patrick.
No, you have to jump. Sorry, I didn't interrupt you.
Yeah, no, I do have to jump. Really appreciate the opportunity to talk with your membership here.
Yeah, I know you have to go, but we did defer some questions earlier in the session around rate setting process. I know we've looked at it in the future, so whenever you've got to go, certainly. But I do want to circle back. If Rick's able to hang on, we welcome Rick to stay. I just want to make the one point about inflation, the inflationary index we've been following. We have taken a position, really the foundation of everything going forward is a substantial investment into rates that mirrors inflation. So we'll circle back with some of the documentation, some of the advocacy that we have done, but any comment at all that you can or want to make around sustainability, the need to invest in the system, the need to get the rates right going forward so this can be successful. I know you can't comment.
I don't know if it was a statement or a question.
I will go back to our last couple of years of advocacy efforts. We want to get money into the upcoming budget, but we also know there's immediate needs. So I do want to follow up after you jump off, just give members a little bit of information in terms of our efforts, our unified advocacy. Most recently, we sent a letter to Governor Shapiro on November 15th, sort of re-emphasizing, reaffirming our request from earlier in the year. We'll walk through that in just in a couple of moments with our members, but is there anything that you can say about the investment based on inflation, the inflationary index, in continuing to invest for the out years? I know these are difficult questions, but the sustainability for lifelong care, that's something that we're very invested in and continuing to advocate for here. Any comment you can make, I just wanted to give you the opportunity.
Yeah, and obviously I can't say much in terms of rate setting. Patrick and Rick, I don't know if you have anything to add there, other than I think you're familiar with the rate setting methodology that we use, and that is what we are using going forward here.
And inflation.
Thanks very much for your time today.
Hang on, Rick is gonna chime in here.
I was just gonna say that inflation is certainly encompassed in the BLS data that we use. So.
Yeah.
Okay, Rick, can you hang on or do you have to jump too?
And hang on if you want, Patrick.
Okay.
A while longer.
All right.
Kristen,
thank you.
Thanks very much. We appreciate your time today. Rick, is there anything more on this deck that you want to cover, or I can just for a few moments, as we wrap up here, I kind of wanted to go back to some things. You're welcome to comment. I appreciate you being here to sort of, listen to what we kind of review. I don't think there's anything here that you're unfamiliar with, but is there anything that you want to circle back on, Rick, that we've just covered?
Not particularly, Patrick. I guess I would. Kristen alluded to this, but just right out of the box, I think there shouldn't, and we don't have this expectation. I mean, not every provider is going to, and probably the less than the majority are going to fall in one of the select, or one of the enhanced or primary tiers, or the A tiers, I guess is what I'm saying. So the expectation should not be that if you're not in the A tier, you're not wanted. We want to move in that direction, but it's not going to happen right out of the box.
Understood. Thanks, Rick. We know there's a lot to be built. We understand the messaging around providers will continue to be contracted providers. I think we understand that a lot of those implications are down the road, but nevertheless, that is of concern, of course, to people doing that work. Ed expressed and articulated the concern very clearly around, particularly not knowing what tiers look like. What's the advantage? What additional costs does it take to really, for instance, get a fully credentialed staff or significantly credentialed staff and frontline supervisors, and to put things in place that are required to be in one of the preferred tiers. But we appreciate the time. Thanks for circling back on that, Rick. I think that, the only things that I really want to cover for membership are sort of talking a little bit about our advocacy for the year, and then briefly kind of look at inflation. And Rick, you've been really directly involved in a lot of these discussions. I'll say for our participants here today, Kristen and Rick, we all have regular communications around the types of issues, and generally share information pretty openly in terms of data that we're preparing, any letters we put together, any recommendations we've shared with you as members in your advocacy, we've certainly shared with Rick, Kristen, and ODP. So in kind of a summary of our advocacy for this year, and I want to revert back also to the president of our board, Ruth Siegfried, really at the end of 2022, assembled a group of CEOs from around the state. One of the things that was really the main theme was the need to have a broader and more unified IDA coalition doing advocacy work. So when you kind of look at this past year, we had a letter in January 26th, we made an original request to Governor Shapiro. There was a clawback to the intellectual disabilities and autism line item. A pretty significant number came out of the budget in this current year. So the associations, again, collectively responded to that issue. The associations across PA collectively sent a letter to Kristen requesting an immediate review of IDA rates. On September 8th, the governor at the National Alliance of Direct Support Professionals National Conference in Pittsburgh announced that he had ordered that review. On October 6th, a report was published by the Center for Healthcare Solutions indicating the current turnover, vacancy factors, the average rate of pay across Pennsylvania, because as many of us know, and as Rick certainly knows, the data that ODP and Mercer uses is not Pennsylvania data. It comes from the Bureau of Labor Statistics. So we really wanted to show and demonstrate to the administration exactly what's happening in PA. And on November 15th, as I've referenced, we basically reaffirmed the amount of funding that we needed because it was predicated on inflation. And the thing that I looked at as recently as really yesterday in preparing for today's meeting, if you kind of look at the CPIU index, which is how we have always made our arguments in terms of how far behind are the current rates. If you look at the most recently published data, it literally comes out to 20% since the May 2020 data. Why do we use May 2020? Because that's the BLS data originally used. Now that was trended forward by 3.5%, but May 2020 BLS report data. Is that correct, Rick? The BLS data is published annually. You look at various codes, they're not DSP codes. And I don't want to put words in your mouth, Rick, but you and I both know we talk about these inflation numbers quite a bit. They're rooted in what's published by the federal government. So, this is pretty much where the system is in terms of being behind inflation.
Yeah, I would agree conceptually, Patrick. I would just correct one thing that, where we can, we certainly do use PA specific data. It's not national data on wages.
Yeah, understood, Rick. And I'll just say that, you're also aware we provided a pretty detailed list of recommendations during this current rate review. Our understanding had been both from ODP in engaging this review and from the budget secretary and the budget office in Pennsylvania that November was kind of the month where the heavy lifting would get done in terms of money being invested into the budget. So the second week of February 2024, Governor Shapiro will put a budget out there. We're really interested in making sure that there is a sufficient investment in the IDA system in that budget. We know the difficulty of trying to get that money and investment after the fact. So, Rick, we appreciate you, ODP's efforts to really engage this. We, of course, will continue to advocate that those recommendations, I won't go through them here, we'll share them with members. Rick, I know that you're aware of them. And Rick, I also want to acknowledge the efforts you, Kristen, ODP made in terms of the update to the audited financial requirements in ODP announcement 23076. You were with us back in September. I also want to thank Lisa Ritter, who articulated some of these issues from auditors' perspectives. We had some members that I know communicated with you directly. I know Warren Kern participated in some of this discussion. So thanks to you and ODP, that requirement has been removed. That update was turned around pretty quickly. And with that, Rick, I'll give you the last word here on anything you'd like to say or update us on. I want to thank you and Kristen for joining us today.
Yeah, no, I think I would just like to say that your advocacy efforts, I think are effective and I think have been particularly effective this year. So I would say keep doing what you're doing. And regarding the financial statements as well as the NEA changes, as well as performance-based contracting, I think I hope the takeaway is that we are not trying to impose undue burden on providers. We're trying to gather better data so we can effectively move the system in the right direction. And that's really what this is all about. So thanks for having me, and thanks for letting me participate.
Sure. Thanks for the comments, Rick. And a happy December, happy holiday, healthy holiday season to everybody out there. Thanks for joining us today. We will follow up with the reporting materials that we've talked about today, some of the links to register for some of the upcoming trainings. Thanks very much, everyone. Have a great rest of your day, rest of your month. We'll see you next time.